going into the review of literature and the thematic synthesis, we can say that most of the systematic reviews and meta-analysis and literature synthesis and associated surveys and qualitative interviews with patients who were incarcerated, that there was a continuum of care need for those that are released from prison to prevent overdose, relapse, and reincarceration. That was a very common theme amongst several of the articles. The other thing that was interesting was that professional organizations have done a lot of research, and therefore organizations like NIDA or the National Institute of Drug Abuse have developed evidence-based tools, screening tools that identify these patients with OUD and appropriately refer them to the level of care treatment that corresponds with their screening. So those are called a quick screen and a NIDA modified assist. And so the order of treatment, according to the synthesis and putting all those articles together, we conduct a NIDA screening, we continue with medication-assisted therapy, we combine cognitive behavior intervention with that, and we assertively and extensively, in detail, address the social determinants of health, not only while they're in prison, but as a transition and as they're released into the community. Screening for OUD upon entering prison was very important in many of these articles, identifying it and treating the patient for withdrawals rather than depending on abstinence for them to recover. So the evidence was clear that abstinence was not useful, and it did require induction of medication-assisted therapies like methadone, buprenorphine, naltrexone to target those dopamine receptors to control those cravings. A tool that was used to identify the withdrawal was COWS, and that tool, the Clinical Opioid Withdrawal Scale, sorry, I almost didn't say that, and that tool was very effective in identifying the level of withdrawal and the treatment guideline for that. The other theme identified was the fact that MAT does treat, not only treats the withdrawals, but it prevents the overdose rate. It did reduce relapse and increased adherence and remission to opioid use disorder. And it did fare better in some studies with cognitive behavior intervention. And then with some studies, it did not. So the evidence wasn't clear as to why, but in certain aspects of CBI, because CBI includes so many different treatments, it sometimes sometimes help these patients without medication-assisted therapy. So that was very interesting as well.